Is there space for innovation in mitral valve repair? Yes. That's all my talk is. So, you're welcome. I thought about just putting up one slide and saying yes and sitting down, but in innovation, in any field, but in mitral valve field, an innovation to have an impact upon humanity has to do two things. It has to be simple and it has to work. We've seen lots of things in medicine that have been simple. For example, radio frequency ablation of the renal arteries for uncontrolled hypertension. Very simple to do, it just doesn't work. And we have lots of things in medicine that work very well. 29 years ago, I did my first cut and sew maze procedure. It works really well, but it's not simple and it's not adoptable, and therefore it has no impact. So for an impact to work, it has to be both simple and it has to work. So you have to say, is there a need? And so we have to look at the 2014 guidelines, which just came out, and say, where are we right now and what are our needs? And for the first time really in the guidelines, they've divided mitral regurgitation into degenerative and functional disease. These are not the same. Our thinking has really changed over the last 10 years. Degenerative MR is not functional MR, even though the word mitral regurgitation appears in both of them. One is clearly a valvular disease, and one is a disease of the ventricle. Secondary functional MR, for the first time, is recognized as a different thing. This is a ventricular problem, either occurring with a myopathy or with ischemia, but it's a problem with the geometry of the ventricle. And of course, even guideline-directed medical therapy results are bad. They're really bad, and the patients die quite a lot. So we do need innovation in this area. The first innovation, of course, was very simple. It was an undersized mitral valve repair. It was feasible. It was low mortality. But we really were like carpenters. We only had one tool that was a hammer, and everyone looked like a nail to us. We only had a ring to fix mitral regurgitation. We realized it was a three-dimensional problem that we were trying to fix in one-dimensional, and it was probably too simple. And the papers came out, it works, it doesn't work, it works, it doesn't work. We did not get rid of FMR. It was a simple solution, but it didn't work. This is a series from the Cleveland Clinic of 500 mitral repairs for functional mitral regurgitation that were done one afternoon, perhaps, at the Cleveland Clinic. And they were followed, and within the first year, 30 to 40% of them had recurrent mitral regurgitation. Obviously, it was not working. And it turned out that for us at that time, large, flexible, or partial bands were not a durable solution for functional mitral regurgitation. So you test an innovation, you test and you retest and you reiterate and you retest, and it turned out that the size of the left ventricle and the type of ring were probably the determinants of outcome for functional mitral regurgitation annuloplasty. Truly, there are some left ventricles that are too far gone, and they have to go down another road to LVAD or transplant. And the type of ring really changed, and innovation here was to iterate, and now most groups who take on these functional mitral regurgitation patients clearly use small, rigid, and complete rings in this group of patients. So, for FMR, the gold standard is undersized, rigid, complete ring annuloplasty. Or is it? We really have to retest and rethink all of our innovations in any field, including the field of mitral valve surgery. So this study just came out recently and caused an unbelievable amount of confusion in my mind. This is the severe mitral regurgitation paper published in the New England Journal. 250 coronary patients with ischemic functional mitral regurgitation were randomized either to have mitral valve repair or mitral valve replacement. The primary endpoint was left ventricular end systolic index, or basically size and remodeling. Secondary endpoints were mortality, cardiovascular events, and functional status. It was all the same. There was no difference between mitral valve repair and mitral valve replacement. Well, how could that be? We have always been taught that repair, whatever the disease was better than replacement. Well, what was different in these patients was that 32% of the patients in the repair group had recurrent mitral regurgitation, as if they had a sham placebo mitral valve repair. This would be me as a general surgeon taking 100 patients to the operating room with colon cancer, and in 1/3 of the patients leaving the cancer in. We would be very confused about the outcome. We did not get rid of functional mitral regurgitation. And in fact, when we test an innovation, we have to test it wisely. The mean ring size in this group was 28.4, plus or minus 1.9. I was a math major in college, and I understand that these rings were therefore not downsized at all, that 25% of the rings were at least a 32. The double downsizing meant that some of these patients in this group had a native annulus of 36. That is impossible in functional mitral regurgitation. And not a single 24 was used in this trial. Double downsizing again, that means the native valve size was never less than a 28. Not possible in ischemic mitral regurgitation. There was no mandatory coaptation length. There was no residual MR. Prohibition, meaning you could come off bypass with MR. However, it was interesting what we did learn from this innovative trial was that the operative mortality for mitral repair was much less than mitral valve replacement. Total valve-sparing mitral valve replacement, which was thought to be just as good as repair, is not in terms of the operative impact upon the mechanics acutely of the left ventricle. And in fact, this interesting slide shows that the functional status of all of these patients, if you compared the groups between replacement and repair, was the same. And in fact, it was shading towards the repair groups being better, even though 1/3 of the repair group had sham, basically nothing done to their mitral valve. Well, the other shoe dropped in Toronto in April of this year at the EACTS, where the subgroups were looked at between good repair, or those did not have recurrence of mitral regurgitation, replacement, and let's say bad repair, those who had a huge recurrence of mitral regurgitation. You can see that all of these ventricles started at about 67 millimeters. They were somewhat large. Bad repair really had very little, down to 63. Replacement also had very little remodeling, whereas the good repairs remodeled tremendously down to 46 millimeters. This tells us that there is still a need to do good repair in these patients. So it's not a matter of just repair or replacement, but can we do good repair? Or should we not even do surgery at all? Is there a different, more innovative way to do this? I, at our institution, do these mitral clips. Again, these are very simple to do, technically very straightforward, very easy, not invasive to the patient, have a very low mortality, but the clip clearly leaves functional mitral regurgitation. Are there studies to show that this innovation actually works? So something to work, remember, it has to be simple and it has to work. This paper from Olaf Franzen showed in this group of patients with functional mitral regurgitation with low ejection fractions, the true group that we're worried about, they have significant mitral regurgitation at 6 months, but some of them didn't. And it may be a very good tool. And again, we test our innovations. It's simple, mitral clip, but does it work? And that's why both the COAP trial and the ReShape trial will be very important to us to show, does this innovation help a certain group of patients? I think Vinay is going to tell us different things about how moving forward with different areas of innovation in percutaneous mitral valve therapy and mitral valve repair and valve replacement will be very exciting in the future. But remember, in this group of patients, it is the left ventricle. And every one of these companies up here has gone broke trying to think that they had the simple idea. These techniques either turned out to be too complex or they just didn't work. This is a very sick group of patients that we have to come up with great innovations. Therefore, the guidelines for secondary mitral regurgitation are somewhat vague. Treat the patient's coronary disease, their heart failure, treat them with CRT, and down at the bottom, surgery or of some type can perhaps be thought of as a 2B indication in the new American guidelines. 2B makes me think of Shakespeare. To be or not to be, that is truly a question. So whether it is questionable whether we should do that or not remains in functional mitral regurgitation. This is in contradistinction to the primary mitral guidelines. Very different. This is a class 1 indication. We know what we're doing. And inside the box, the new guidelines help us show we know everything. There's probably no area for innovation in primary mitral regurgitation. Ejection fraction falls below 60, diameter enlarges, pulmonary pressures rise, atrial fibrillation. If we can operate in these patients with greater than 95% repair confidence and a less than 1% mortality, fix them. We know everything about degenerative mitral valve repair possible. But wait a minute. If we look at this and say, well, certainly if we wait till symptoms, that's bad. We've lost years off the patient's lives. However, if we wait till atrial fibrillation and we wait till pulmonary hypertension and we wait till increase in left ventricular size or we wait to a fall in ejection fraction, that is also bad and it's too late. Why are these guidelines written that way? Especially when their data exists like this from the Mayo Clinic showing early surgery is far superior to too late guideline-directed medical therapy, medical management. Early surgery in these patients not only give them better quality of life, but statistically give them very, very much more quantity of life. And in fact, this has been known for a long time. If we repair degenerative mitral regurgitation, we cure MR. It works. So it works just fine. But the question is it simple? Can we repair it at a 95% rate? And if you look at this from the STS database in the United States, you see that in the United States, we do not. We cannot repair it at a 95% rate. This is all types. And in fact, in our paper from 3-4 years ago, the overall repair rate for all isolated mitral valves was only 41%. If you slice them and dice them, perhaps in the United States right